We trust doctors to make life-saving decisions based on pure medical facts, right? But what if there's a hidden factor? Something that has nothing to do with the heart itself that could be influencing how they treat a cardiac emergency. Today, we're going to dive into a really fascinating research proposal that looks at that invisible line where mental health and heart health can collide. So it all boils down to this one question. Could a pre-existing psychiatric diagnosis actually change the way doctors respond when your heart is in a crisis? Now, this isn't just some hypothetical thought experiment. It's the very real basis of a new study we're going to break down right now.
Okay, so to really get why this question is such a big deal, we first have to understand the medical condition that's right at the center of all this research: atrial fibrillation.
So what is atrial fibrillation, or AF, anyway? Well, think of your heart's upper chambers like a perfectly coordinated rowing team, right? In a healthy heart, they beat together in this powerful, steady rhythm. But with AF, it's total chaos. They just quiver. It creates this kind of electrical storm that throws the whole system completely out of whack.
And this right here is why AF is so incredibly dangerous. I mean, look at this. That chaotic quivering can have devastating consequences. Blood can just sit there and form clots, which can then travel up to the brain and increase the risk of stroke by 5 times. And over time, it can lead to heart failure. Plus, the constant exhaustion and shortness of breath can just wreck a person's quality of life, which is why it's a huge reason people end up in the hospital.
But the good news is, when AFib gets really bad and a patient is clearly in distress, doctors have a pretty powerful tool in their toolbox to calm down that electrical storm and get things back in order.
It's a procedure called electrical cardioversion, or ECV. And honestly, this analogy you see here is just perfect. It's literally like hitting Control-Alt-Delete on the heart. It's a way to shut down all those crazy, chaotic signals and just give the heart a chance to reboot into a normal, healthy rhythm.
And the way it works, it's actually incredibly straightforward and really effective. First, they give the patient some sedation so they're comfortable, totally asleep, feel no pain. Then, a controlled, precise electrical pulse is delivered. And in most cases, bam, just like that, the heart's rhythm is instantly back to normal. It's a high-success, low-complication procedure that gives immediate relief.
Okay, but this is where the story gets, well, a lot more complicated. Because you really can't talk about the heart without also talking about the mind. The two are just deeply biologically connected. Now, this is a really important detail. The researchers aren't just lumping all mental illness into one big bucket. Nope. They're making a very clear distinction between mood disorders, things like depression and bipolar disorder, and psychotic disorders like schizophrenia. And this is so crucial because, as you can see, these conditions show up very differently and maybe are perceived very differently by medical staff.
Look, we've known for a while now that patients with these conditions often have worse heart health. And the reasons are complicated. It's everything from biological stuff like chronic inflammation to behavioral factors. But there are also problems with the system itself, including this really dangerous thing you see at the bottom called diagnostic overshadowing. This is basically when a doctor might dismiss a patient's very real physical symptoms, like chest pain, as being all in their head just because of their psychiatric diagnosis. It's a huge problem.
So you take all of this known link between mental illness and bad heart outcomes, and it leads these researchers to ask a really tough, maybe even uncomfortable question.
Here's the thing. We already know there's a problem. We have studies that show in just routine, day-to-day care, patients with mental illness are less likely to get prescribed essential heart medications like blood thinners for their AF. So a disparity already exists. But what happens when things get serious, in an emergency? When a patient is right there in the hospital, actively suffering from acute AF, does that same disparity hold true? Are doctors less likely to hit that Control-Alt-Delete for the heart if the patient also happens to have a diagnosis of schizophrenia or bipolar disorder? That is the critical question we just don't have an answer to yet.
So, how are they going to find the answer? Well, they're proposing a deep dive into one of the largest medical databases in the United States. Think of it like big data for a very human problem. The scale of this is just massive.
They're planning to use something called the National Inpatient Sample. Get this, it's a data set that covers about 20% of all hospital stays in the entire country over a 6-year period. By using that much data, they can be sure their findings aren't just a weird fluke from one hospital, but a real snapshot of what's happening nationwide.
And their plan is actually pretty simple, but it's really clever. They're going to find all the patients who are hospitalized for AF and then sort them into 3 groups. One with psychotic disorders, one with mood disorders, and a control group with no psychiatric diagnosis at all. Then they'll just ask one main question. Did they get the ECV procedure or not?
And he doesn't stop there. They're also going to look at what happened to these patients while they were in the hospital. Did they make it? Did they have a stroke or a cardiac arrest? How long did they have to stay? This connects the decision to do the procedure, or not, with actual real-world life-or-death outcomes.
So after they crunch all the numbers and account for all the other medical factors, age, other diseases, the kind of hospital they were in, you name it, the goal is to isolate just one single thing. Is the psychiatric diagnosis, all by itself, a factor that determines whether a patient gets this standard life-saving procedure? In other words, is there a hidden bias at play here?
At the end of the day, this is all about fairness. It's about health equity. If this study confirms that there is a disparity, that's the first huge step toward fixing it, with better guidelines, more training, more integrated care. It's about making sure the care you get for your heart doesn't depend on the condition of your mind.
And that leaves us with a final thought. This study is just looking at one procedure for one condition. And it really makes you wonder, what other hidden biases might be shaping the medical care that we or the people we love receive every single day? And what can we do to finally bring them into the light?